Okay, I think we're ready to go. We're recording. Good evening, everybody. Everybody, please mute your phones and keep them muted. Today's talk is entitled Dr. Friedman's New Approach to Thyroid Medicine Timing. I think you'll find this to be a fascinating talk, and I think this is going to change how we treat people with hypothyroidism. Our outline today is we're going to go over my new approach to thyroid medicine timing. It's going to be based on an article in the Journal of Clinical Endocrinology and Metabolism, JCEM, that discusses taking thyroid medicine on an empty stomach versus with food. So we'll talk about, can you now take thyroid medicine with food? Should you take thyroid medicine with food? Can you take thyroid medicine with other medicines? Do you have to adjust the dose of your thyroid medicine if you're changing from without food to with food? Should you get your blood test done before or after your thyroid dose? And can you take non-desiccated thyroid or desiccated thyroid extract or levothyroxine, liothyronine containing medicines once a day? The thyroid is in your center of your neck, as everybody knows. There's two lobes. It's a butterfly shape organ that's above your trachea. Thyroid hormone makes two active hormones, T4 or thyroxine, and T3, which is iodothyronine. It also makes what's called reverse T3 also, and it makes T2, which is inactive. We're going to mostly talking about the synthesis and release of T4 and T3. There's feedback by the pituitary hormone TSH, so that when the T4 and T3 rises, TSH shuts down. And this can be somewhat transient, that if it rises for a little time during the day, this can suppress the TSH. TSH in turn feeds back and regulates the thyroid to make more T4 and T3. There are many options for thyroid hormone replacement. Many endocrinologists use levothyroxine or LT4 alone. Some of the brands are generic levothyroxine, Synthroid, Levoxyl, Tyrosint, and Unithroid. There's gel capsules, Tyrosint, generic Tyrosint, and Thyquidity. There's T3, Cytomel or liothyronine alone. There's combinations of T4 and T3. There's desiccated thyroid. These is probably not available. It's been available for the last couple of months, although some places pharmacies may still have some. Armor, Nature Throid, WP Thyroid is really also no longer made. Urfa is a product in Canada. These often come from pig thyroids. Around the world, there's other products. These are often called natural desiccated thyroid, or NDT, or desiccated thyroid extract, DTE. Usually call them desiccated thyroid. You can take desiccated thyroid plus levothyroxine, desiccated thyroid plus thyronine. And in general, the proper treatment needs to be individualized. You don't have one blood pressure medicine. You need to individualize the treatment for hypothyroidism. Interesting, there's about multiple studies, including review articles, have shown a poor quality of life among patients, about 15 to 20% of them on levothyroxine alone, even though they have a normal TSH value. A lot of studies trying to figure out why. The classic approach is to avoid poor absorption of your thyroid medicine. Clinical guidelines and experts recommend avoid taking thyroid medicine with food, iron, calcium, vitamins that have iron or calcium, proton pump inhibitors such as uh, pantoprazole or omeprazole, carafate, oral bisphosphonates, of which they use for bone osteoporosis called Fosamax, orlistat, or cholestyramine. And it's unclear how long the separation period should be. Some studies have recommended, some guidelines recommend 30 minutes, others up to 4 hours. And you can imagine if you're taking a couple times a day the dose, and you have to separate it from food or medicine by 4 hours, it's going to really cramp your life. And many of my patients really have trouble following some of these guidelines. There's little studies that have validated these ranges and time to separate your medicine. There was just some studies that suggest taking it at night so it doesn't interfere. Some of my patients who wake up in the middle of the night, which I don't recommend, so it's separate. So I think there needs to be much more studies about this, and this paper seemed to answer some of those studies. A tyrosine, which is a gel capsule, there's both a liquid form and a gel capsule form. It seems to be better. There are some studies with tyrosine that food doesn't interfere with it, and it can be taken. with food or with other medicines. Well, this is a paper published in Journal of Clinical Endocrinology and Metabolism. Came out in the April issue, and just entitled "Fasting versus Non-Fasting: Dose-Adjusted Levothyroxine Ingestion and Hypothyroidism, a Randomized Clinical Trial," and it's from the Netherlands. The introduction to the paper talked about that clinical guidelines recommended levothyroxine to be taken on an empty stomach between 30 and 60 minutes before breakfast and separated from medicines known to interfere with absorption. And this is to prevent reduced gastrointestinal uptake or uptake from your stomach. This group did a questionnaire study that 50% of people reported that delaying breakfast was burdensome. One third admitted not consistently adhering to the recommended timing, and some reported regularly forgetting to take their medication due to the fasting requirement. I think people are used to taking it when they wake up in the morning, and if they have to wait to take it, they often forget to take it. This contributes to suboptimal levothyroxine therapy. Additionally, 25% of patients reported skipping breakfast altogether to meet these fasting conditions. And they referenced several papers, including some prominent review articles and a systematic review about levothyroxine. Um, this led them to do the study that these observations raised the question of whether routine co-ingestion of levothyroxine with breakfast could be a viable alternative to fasting, provided that the expected reduction in absorption is offset by increasing the dose. So the idea is if you're going to absorb a little less, you give a little bit higher dose. Therefore, they conducted a randomized, dividing people into two groups, clinical trial comparing traditional fasting levothyroxine intake with levothyroxine intake along with breakfast, accompanied by a 15% dose. So the people that took it with breakfast, they were given 15% extra. So if they're on 100 micrograms, they were given the equivalent of 115 micrograms. And they assessed whether this alternative regimen could maintain TSH stability. They didn't want the TSHs to either drop or rise, and improve patient satisfaction among individuals with well-controlled hypothyroidism. They took people already on levothyroxine, well controlled with a normal TSH. Eligible patients were randomly assigned to either the fasting group or to the breakfast group in a 1-to-1 ratio. This was an open label trial. It wasn't blinded. The patients and the investigators knew what group they were allocated to. Fasting group was instructed to take their levothyroxine 30 to 60 minutes before breakfast. Breakfast group was instructed to take their levothyroxine with breakfast with an empirically chosen 15% dose increase to compensate for the expected reduction in absorption of levothyroxine. The use of interfering drugs, including calcium, iron, magnesium-containing supplements, vitamin supplements, potassium and phosphate binders, proton pump inhibitors, and H2 receptor antagonists, was allowed. However, they're instructed to maintain a 4-hour interval between the levothyroxine and these medications and to report any dose changes or new prescriptions. They then, after they finished the study, which I think was for 6 months, they then had a crossover period where the patients in the fasting group could go into the breakfast group. They didn't have it the other way around. They just had the fasting group and go into the breakfast group. They defined TSH stability as 2 consecutive TSH measurements remaining within the reference range and the change of 1 unit different from baseline. So the TSH was at 4 and 3 at baseline. They were allowed to go up to 4 or to 2, but they couldn't go more than that. This is the results section. The TSH was stable in both groups without a significant. In the fasting group, 74% of the patients had a stable TSH. Again, it didn't change much. 73% in the breakfast group, this was not significant. This is on the right, it shows a scatter plot of the mean change in TSH from baseline. Again, no significant change. In the breakfast group, there seemed to be one patient at the bottom there that did change a lot, but that was just an outlier. I think the rest of them were quite stable. They took the crossover group, and of the crossover, 77.8% of the crossover patients, the one that switched from fasting to eating with breakfast, they preferred the levothyroxine with breakfast over fasting ingestions. This was actually the same patients. The other group, it was just 2 different groups of patients. In the crossover, it was actually the same patients. When they switched over, they preferred to eat it with breakfast. This is the results. On the left is the self-reported well-being. And you can see that the breakfast group, 33% had an improved sense of self of well-being. 62% were stable and 4.4 decline, while in the fasting group, it was 16.3. So the amount that took it in the breakfast, their sense of satisfaction doubled, which I think is quite remarkable. The sense of well-being doubled. So they reported being felt better. They did better in the breakfast group, and they whether they preferred taking the levothyroxine, the breakfast group 76% preferred to take it in the breakfast group, while in the breakfast group 76% preferred it to be non-fasting with no preference in 14, while in the fasting group it was about evenly divided. So these are, I think some of these are the crossover group, but in general, patients preferred it to take it with breakfast and have to worry about fasting. The conclusions in this randomized proof of concept trial in patients with well-controlled hypothyroidism, 15% dose ingested levothyroxine medicine with breakfast achieved a similar TSH stability compared to fasting levothyroxine ingestion. Self-reported well-being tended to be higher in the breakfast group, with 88% opting to continue breakfast ingestion after study. So once they went on breakfast ingestion, non-fasting, they liked it and want to stay on that. Patients who switched from fasting to breakfast ingestion reported improved well-being. Key benefits included a more consistent breakfast routine, improved drug adherence, relief from stomach discomfort, and both psychological and physical benefits, i.e., they felt more physically fit. And they didn't examine interfering drugs. My view of this paper was that it's an excellent, important, innovative paper. There were fairly small numbers in the group. They relied a lot on the crossover data, which I think had only like 14 patients or so, but that was a really important group because they were that group was on both treatments and they liked being on the eating with breakfast group. And I always thought that this timing from food was overstated. There was little data on it, and in general, I always thought that I adjust their patient's dose based on their lab results. So as long as they're fairly consistent, I look at their lab results, and if the thyroid tests show they need a higher dose, I would give them a higher dose. As long as the patient was on a fairly consistent dose, and adjusting for the next time around is based on labs. In other words, if you take your thyroid medicine with food every day, your labs will reflect that and your dose can be adjusted. If you switch from fasting to taking it with breakfast, you may need a higher dose. And I think that's more important to take it daily, even if it's with food, than really have this restricted life that many of my patients report. I think the same thing's going to happen if you take it with interfering medicines, but that wasn't tested. And I think your patients can separate them for sure. It's easier to adjust your medicines than adjust your food, I think. Most of my patients, I recommend taking the levothyroxine or the desiccated thyroid twice a day on a waking and mid-afternoon, which is waking is a little bit separate from food. But in general, I don't think you have to wait that long. So get up in the morning, pop your medicines right out. As soon as you're out of bed, they're in your medicine cabinet, you get dressed, you're out of the bathroom. Whether it takes 15 or 20 minutes or half hour or so, 10 minutes. And then you can eat your breakfast or drink your coffee. So again, I think based on this paper, you don't really have to wait that much time. And the people did better if they ate it with breakfast. It didn't fast. Now I'm going to get into an interesting area about levels after eating it. And some of these are AI generated, some of these are data generated. But when you take your medicines, your levothyroxine, for example, the dose goes up by about 12 to 14%. And there was a paper that I wasn't a co-author of, but I was involved in it when I was at the NIH in the 90s. That was one of the first papers to show that. So you take your values you take your levothyroxine, you measure your free T4 afterwards, the dose is a little bit higher, up to 30 to 20 to 30% higher. And this shows compared to the trough levels before you take it, peak levels after you take it. And you can see here that the levels are higher. You can see the scale is up as high as 30%, as low as 10%. Within about 2 hours or so, they get higher, and then they come back down to normal. So if you get your blood test done after you take even your T4, it's a little bit higher. Now, what about T3? T3 is even more dramatic. So here, when you take your T3, it could be 2 to 3 times higher, after taking it, within an hour, 2 hours after taking it, as shown in this figure here. So I think especially with the T3, it's important to do it trough values before you eat, but even the T4, it's important to do it before you eat. And this is a AI schematic that shows what happens. The levothyroxine peaks in 2 to 3 hours, the liothyronine peaks in 3 to 4 hours, and then they return to baseline. With food, concomitant food intake, especially high fiber food, reduces the vitality and delays the peak concentration by 15 to 40%. Liquid levothyroxine, such as tyrosine, it seems doesn't affect it, reducing the need for strict fasting. Pharmacokinetics in fasting with levothyroxine peaks around 2 to 3 hours by a long half-life, a tail up to 7 days. And with food, it's broader. It doesn't peak as much and is shifted to later. So that's an important concept. When you take it with food, you don't have this quick, rapid increase. You have a broader increase, which I think is going to be beneficial of that in the next couple of slides. With the T3, it's the same thing. With food, it delays your absorption. This AI area thought it was less dramatic than T4. I've seen other papers and suggestions that it's more dramatic, but in general, it's the same thing happens when you take it with food. You get less of a peak. It's a little broader. It's a little more throughout the day. So in general, with the T3, big increase after you eat, especially around 2 hours, followed by a decline. This is a paper, an article from a paper by Bianco, Antonio Bianco. And this shows modeling of taking 50 micrograms levothyroxine 3 times a day in A, twice a day in B, or once a day in C. And you can see that when you take it 3 times a day, you still get a lot of jaggedness when you take it. It's the time is in hours. And you can see every time you take it, you get a pulse and a trough, but it's more stable. It's not as dramatic as the once a day. So you can see the once a day, you're really up high and then down low. And the twice a day, you're still have a lot of going up and going down. And then and then when you take it 3 times a day, again, it's still jagged, it's still pointed, but it's more, it's flatter. On the right side is somebody that's taking a levothyroxine dose of 112 micrograms being transitioned to a levothyroxine plus liothyronine combination therapy. The first one is if you take 3.25 micrograms twice a day plus the levothyroxine. The second one is 5 micrograms twice a day plus the levothyroxine. And the third is 10 micrograms twice a day plus the levothyroxine. Here you can again see that if you take it 3 times a day, you're flatter, you're more even, you still have pulses. If you take it twice a day, you're still a little flatter. You're a little less flat, but you still have pulses. If you take it once a day, twice a day, you're at a higher dose, and you have even more highs and lows. It really shows that if you take the T3, your levels go up pretty dramatically after taking it. But what happens with food? Again, this is an AI generated diagram. And you can see here that the green is fasting, the levothyroxine levels. The no, sorry, let's do the blue first. The blue is the levothyroxine with fasting, and the orange is the levothyroxine with food. You can see it peaks a little later, and it's a little bit more spread out with the food. So you don't have this big rise and then decline in the T4. What if you take T3? It's even the same thing. It's even more dramatic. The green is the T3 after taking free T3 after taking T3. It goes up really high and then comes down really rapidly. But with food, it's more delayed. The food is going to be the sort of reddish color. It's more delayed. And you get, if you take it with food, and this is going to be the same, you'll see with levothyroxine, with desiccated thyroid in the next slide, all of them, you get a big increase, and then food delays the increase and makes it more flat, more even. When it's more even, you get less of a suppression of your TSH. And this accounts, I think, for why patients have a lower TSH on levothyroxine when they take it on an empty stomach than if they didn't. In other words, if a patient has a TSH of 1, you say, oh, this person is perfectly replaced. but they took on an empty stomach, it really may be a TSH of 3, and they may feel a little hypothyroid. Maybe this explains why some of the people have a normal TSH and don't feel well because they're really on their TSH might be 2 points higher than what it looks like if you take it on, if you would have taken it with food. I think there's advantages to taking it with food, and I think that's possibly one of the reasons, beside the fact it was just more convenient, why in the paper JC&M the people liked it better with food. Okay, so this is an AI generated model with food, a little complicated, but I'll walk you through it here. So the blue is the levothyroxine level with food, with fasting, the blue, and the hatched blues right here are the levothyroxine with food. So again, it's delayed. And then the free T3, the same thing. The green is a big peak fasting, and um, the hyphenated green right here is the T3 with food. So again, it's delayed. And then this model looked at TSH suppression. So I think you don't want as much TSH suppression with the dose. So the top bar shows the the top bar shows TSH that's with a dotted sort of orange color or a reddish color. TSH that's with food, you don't get that much TSH suppression if you start having with levothyroxine. If you have the levothyroxine with fasting, it would be that little darker reddish color. You have more TSH suppression. And if you take the T3, you have even more TSH suppression if it's fasting and less if it's with food. But the food is still more of a TSH suppression. So again, if you take TSH support, the TSH gets suppressed, you have more effect on you're seeing like a lower TSH compared to your actual value. You want an even value. You don't want your TSH suppression. Okay, and this is desiccated thyroid extract. Again, this is a model. You can see the PT3 levels with desiccated thyroid extract are green. With fasting, they're high. With food, they're lower. And then the free T4 fasting is the blues here. And then over here is the desiccated thyroid with food. Again, it's flatter. And this shows the TSH suppression is more with fasting down in here than the sort of darker reddish color. The lighter reddish color shows with food less of a suppression. These are purely AI generated models, but I think they're pretty accurate. So the question is, and patients always ask me this, and their endocrinologists don't really understand this, is it okay that people on T4, T3 combinations or desiccated thyroid extract have a suppressed TSH? And I think the reason why they have a suppressed TSH is when they take their T3 in the morning, their desiccated thyroid extract in the morning that has T3 in it, that high dose suppresses your TSH, and that last suppression lasts throughout the day. While the rest of the day, they're probably okay. So I would say, yes, it's okay to have a TSH suppressed. You may not want it to be absolutely zero, but it's okay to be suppressed as long as your free T4 and free T3 levels are, trough free T4 and free T3 levels are okay. As long as you don't have signs or symptoms of hypothyroidism, as long as you don't have heart disease. And then I often look at a bone turnover marker called a urine enterolipeptide. And as long as that's not high, I also feel pretty good that they're not overtreated. Should you get your blood test done before or after your morning thyroid dose? Before represents the trough, after represents the peak. And as I showed before here, you should get it, they're higher after you take your medicine. So you should try to get your labs done first and then take your morning dose. So you're in the trough area, otherwise they'll be falsely high. So I summarized this from another website. When researchers monitored the levels of T4, T3, and TSH in people with hyperthyroidism who were taking a combination of thyroid medicines over a 24-hour period, they found that TSH levels may be falsely suppressed for 5 hours after taking a T3-containing medication. TSH then begins to increase 5 hours after the dose and continues to rise until 13 hours after dose, at which time it's stable. T3 levels are also affected, increasing after the dose is given and hitting a peak at 4 hours. This means if you take your want to take you were to take your thyroid medicine within 5 hours of getting your blood test done, your lab tests might show you're overdosed even when you're accurately dosed. Or they may show your labs to be within normal limits of which you're underdosed. So thus it's best if you're taking thyroid medicines, even T4 alone, but I would say desiccated thyroid or T4, T3, it's best to get your thyroid test done first thing in the morning, make an appointment at your lab, bring your medicines with you, and take them right after you have your thyroid test done to ensure you get accurate results. So I think with this in mind, in general, I try to give patients desiccated thyroid. I always do it twice a day because of the T3. But I've seen in this, you still have these peaks after taking it that can falsely suppress your TSH and lead to, just a little bit of hyperthyroidism throughout the day. So therefore, it might be reasonable for some people to go on 3 times a day thyroid medicine and a lower dose spread out. And I did that on a patient I talked to today. I put some patients on a T4, T3 combination. Both of them, the T3 has a short half-life. That means it peaks and then it's gone throughout your system. So if you take it once a day, desiccated thyroid T3, you're hyper after you take it and hypo in the evening. And by the next morning, you could be quite hypothyroid. So therefore, it does need to be at least twice a day, maybe 3 times a day. A desiccated thyroid has other proteins in it, which is sort of the same as food. It might delay some of the peaks, but it may not. But I think having the desiccated thyroid has an advantage over T3, and it's more likely to be stable throughout the day. I don't use that much of compounded T3, but there may be some pluses of taking compounded once a day or twice a day compounded to again try to avoid those peaks after taking it. So the paper answers these questions. Can you now take thyroid medicine with food? I think the answer is definitely yes. Should you take the thyroid medicine with food? I think there's pluses about that. I think you're going to get a more even absorption and a flatter curve of your levels of T4 and T3, and you'll have less suppression of your TSH. And you take thyroid medicine with other medicines. This was not looked at in the paper. My guess is probably going to be the same thing. You probably will be able to, and you need to adjust your dose. As long as you're consistent, you may need to adjust your dose. So if you're telling me you're going to go from taking it with food, with fasting to taking it with food, I may give you a slightly higher dose as this paper recommended. If you're on somewhat of a stable dose and you decide you're going to just do a little bit, spread it out a little less, maybe instead of waiting 4 hours, you're going to take 1 hour. Instead of waiting 30 minutes, you're going to wait 15 minutes. We may not need to change your dose, but the next time we'll be able to see that adjusted. Should you get your blood test done before or after your thyroid dose? The answer is before. And can you take your NDT or levothyroxine medicines once a day? No, you need to take them twice a day. So I think this is a pretty short webinar. It was a half hour. And we'll post this on my website, my Facebook page. We'll have time for questions. It will be on our podcast, and you can go on our Facebook page or email us any questions.
Great. Thank you, Dr. Friedman. I have a few questions on Facebook that we can get started with. James asks, when you say twice a day, what's optimal points in the day to take the second dose?
I usually have people take it first thing in the morning and mid-afternoon, about 2 or 3 p.m.
So, Gina asks, Dr. Friedman, how are the thyroid drugs absorbed differently in a patient with a post-Royan gastric bypass surgery? I definitely have trouble absorbing oral hydrocortisone and was curious. I am also on T3, T4 combination twice a day.
So the Roux-en-Y is a gastric bypass, and it does affect absorption. So people potentially would absorb it poorer. They may have maybe more delayed response, but I think it's going to be the same thing. That we'll look at your levels next time, or your doctor, if you're not my patient, will look at your levels next time and adjust it based on what your levels are. But I think people with gastric bypass worsening have delayed absorption.
Okay. Annette asks, is there any studies on dissolving meds under the tongue versus swallowing? Any significant difference? Thank you so much.
Okay, yeah, I don't think there's any significant difference. And I think most of the studies are done by swallowing it. And I think, as I said, I think I like it with food. and swallowing it, because then there's a little more of a delayed response. Well, if you take it under your tongue, it might be a more of a rapid response.
Cindy asks, if you have thyroid nodules, how often should we get them looked at?
Oh, I think thyroid nodules, again, is sort of a different topic, but thyroid nodules are almost always benign. Very few people die from thyroid cancer. You don't certainly don't want to die from thyroid cancer, but very few people. In general, the field is going to be more conservative on that. That if you have a big nodule, you should get it biopsy. There's something called a TRAD score, which looks at how the ultrasound, the report of the ultrasound, does it look like it's an aggressive thyroid nodule with a high TRAD score, or an unaggressive one. And if it's a low score and if it's a smaller nodule, you may need to just have it monitored and check to get the ultrasound maybe just one time the first time. If it's a little bit bigger of a nodule with a higher T-red score, you may need to get one every year. And if it's a fairly high score, you may need a biopsy. So in general, we're moving to be less aggressive with thyroid nodules.
Andrea asks, so will taking the thyroid medication with breakfast show on labs, or do you need more medication, or is it just optimal to take more in that scenario?
Okay, so if you take it with breakfast and you weren't, you may have me or your doctor give you a little higher dose to start with. Or you could just wait till your next labs and see what happens, and we'll adjust your labs next time and we'll give you a little bit more.
Salome asks, I have a hard time going to the bathroom on levothyroxine. Any suggestion on that?
I don't know if that's bowel or urine. In general, levothyroxine, if you're undertreated, if you're hypothyroid, you can get constipation. If you're properly treated, you shouldn't. But maybe if you are constipated, you might want to switch to a desiccated thyroid or T4, T3 combination. In terms of urination, I don't think it affects it.
Move on to some Zoom questions. What are the advantages of taking desiccated thyroid 3 times daily? I have a low around 2 p.m., currently taking it morning and late afternoon.
Right. So I think you might be an example of somebody that's metabolizing it quickly. It's out of your system by late afternoon, so you feel low in the early afternoon. So if you were to take it breakfast, lunch, and dinner, for example, that might be a little more even. You take it with food, it stays more in your system evenly, and it's spread out throughout the day.
Okay. Holly asks, what about new liposomal testosterone delivery options?
Right. So I decided to not talk about that today. I thought there'd be enough to talk about with the thyroid extract, and I think I was correct. But I hope to have that talk and maybe my next one.
Okay. Jenna asks, do you ever prescribe just tyrosine to a patient who is hypothyroid?
I do, yes. I use a lot of tyrosine. I take tyrosine myself. Tyrosine is a gel capsule. It's very pure. It doesn't have any binders or fillers, and some people are very sensitive to the binders and fillers. I always say that, we talk about the 20% or 15% of people on levothyroxine are not doing well. That means that the 80 to 85% are doing well. But for many patients, the T4 alone is a good option. It is advantage to be given once a day. And of the T4 alone, then you can just take tyrosine. The disadvantage of that is that, the T3 is like a faster acting, um, hit. It gives you a little bit better energy. And it also, there's something called reverse T3, which I talked about in a prior webinar and have a paper on that. If you take T4 alone, sometimes your reverse T3 goes up and the T3 doesn't bind to the receptor. So I do try to individualize my practice, and some patients I give tyrosine, some people I give T4, T3, and some people I give desiccated thyroid.
Awesome. Frederick, which NDT do you prefer?
I prefer NP thyroid. I think it's a little better formulated than Armor with a little better binders or fillers. I find that Armor thyroid had a little too much T3, not enough T4 in it, and I think um, NP thyroid is a little more balanced on that. That has a better ratio of the two.
Okay. Did you say we cannot get desiccated thyroid anymore, or was that a particular brand?
Right. So this one is a changing story, and I did have an article that went on that. In maybe in the fall of last year, the FDA had concerns about desiccated thyroid, the fact that it wasn't FDA approved, and there wasn't any clinical trials showing that it's effective. There was a lot of pushback in the FDA, especially FDA Director Dr. Makari wanted to keep giving it, and the FDA announced recently that they're going to keep allowing it to be given. Um, I expect it to stay available, and I expect companies that are working on it, especially the Acela that makes NP thyroid, they are going to have clinical trials that are going to show it's effective, and it is eventually going to get FDA approved. The second question is about insurance coverage of it. Caremark in 2019 made up that there was a shortage of backlog of desiccated of NP thyroid when there wasn't. I think this was a purely political situation. And then, after a couple of months, they started giving their members NP thyroid. Now they're saying that they don't want to cover it and that you have to go on T4 to get it covered. I think this is a purely financial decision on their part. But it turns out that the insurance doesn't cover it that well, anyways. And there are things such as GoodRx and different pharmacies that give it to you about the same price as insurance, anyways. So I still do recommend taking desiccated thyroid. I think it's going to continue to be available for the patients.
Amy asks, when I take my T3 2 times daily, I get too hot. So I take my T4 and T3 replacement in the morning, fasting, with flutocortisone and sub-Q solu-cortef injections. Is this okay? I have gastroparesis.
Yeah, it sounds like it's okay. So you might want to again take it. You might want to go on a desiccated thyroid extract. Might be better for you than the T3 because the desiccated thyroid extract is a little longer. Or you might want to take your T3 3 times a day. You can make an appointment with me. We can discuss that, or you can talk to your doctor.
Right. Pat says, I didn't see NP thyroid listed. Is it still a recommended manufacturer?
Yes, I don't know if I wasn't there. I just missed it, but it's definitely available.
Great. How spaced apart should a person with secondary Addison's disease take hydrocortisone and their NP thyroid, which is taken with food 3 times a day?
So the hydrocortisone, first of all, is a myth. It doesn't need to be taken with food. It's really, especially in sort of the physiological doses, it's perfectly fine on the stomach and doesn't need to be taken with food. Secondly, you can take your NP thyroid and your hydrocortisone together. There's no problem with that. And third, as I sort of said in this talk here, you can take both and with food if you want, and there's no problem with that.
Awesome. Shelly says, for those, for those that have had thyroidectomy, the peaks and valleys feel more exaggerated. So taking with food and doing 2 times a day or 3 times a day will help even it out. Or would the dosage throughout even start higher and reduce throughout the day?
Oh, yeah, I think you can consider taking it. You definitely should take it if it's T3 twice a day. And I think if you take, I think the T4, at least right now, most people are okay with taking it once a day. But the T3 and the desiccated thyroid, at least twice a day, and sometimes 3 times a day. And then I think we would adjust your dose of your next labs.
Amy has a question and also said that you are my doctor and you can't retire.
I no problem. We're planning on retiring. Thank you.
She says, my TSH is suppressed and is due to both T3 and steroid replacement. Why? Why don't most endos know that TSH will be suppressed on T3 and steroid replacement for adrenal insufficient? Why do physicians think that just testing TSH will tell them if the patient's FT4, FT3, and RT3 are normal or off? Can you explain why testing TSH is not beneficial when one is on T3 and steroid replacement, please?
Okay, so a lot of questions there. So as I said here, when you have your T4 desiccated, T3 or desiccated thyroid, you get a fairly big dose after you take it, and that suppresses your TSH, even if it's just high for a couple hours. That leads to the suppressed TSH that endocrinologists know about. I know about it, but many doctors don't. In general, the steroids, if you're in a physiological replacement, if you're on like a high dose of prednisone, it's going to replace it. But if you're on maintenance dose of hydrocortisone, sort of 15 to 20 milligrams a day, it shouldn't affect your TSH basically. And then Why do physicians think just testing your TSH will tell them? So if you are one of these patients, the 80% of the patients that are on levothyroxine only, you're doing pretty well, you don't have any other problems, you don't need to see a specialist, it's probably okay to just test your TSH. So when I have my county job, I have thousands of patients on levothyroxine, they're doing fine. I basically check their TSH most of the time. Occasionally, I get patients that aren't doing that well, and I would check their free T4 and free T3, and rarely I would check the reverse T3. But then you have the 20% or 15% of patients that aren't doing well, and those you need to see a specialist like me. You need a comprehensive evaluation with total levels, and you need to adjust accordingly.
Hey, on pace.
And I always still get the TSH. I like to see sort of where it is, even though I really base my guidelines on free T4 and free T3 and reverse T3.
Awesome. Gina said on Facebook, Dr. Friedman, we hope to see you at the Magic Foundation Adult Conference soon.
Totally, it'll be in Denver. Let's
Awesome.
see. I can see Tiffy, and I
Yay.
can see she's still there, and I can go to the conference. Yes.
Yay. Um, Janet said, is your RT3 article on your website? Yes, it
Yes,
is.
absolutely. And also, we did a webinar on RT3 that you can listen to.
Awesome. We'll take a few more questions. Tori asks, I feel just fine throughout the day taking Armor once a day in the morning. It would double the cost if I took it twice a day. Is that okay?
So what you can do, I mean, if you feel fine, that's fine. It's okay. Most of the patients that come to see me don't feel fine. That's why they came to see me. But I would probably still try it to just cut your pill, cut it in half, and take it twice, a half a pill twice a day. It's the same cost. My guess is you'll feel a little bit better on that than you would be otherwise. So you can try that first and try it for yourself.
Okay. Dr. Amy asks, would it be better to take NP thyroid with food with meals spaced evenly hours apart as I work in the evening and at night, or just say typically 8 a.m., 1 p.m., and 6 p.m.? I think I'm overthinking this. Looks like we have two Amy's on here that never want Dr. Freeman to retire.
Right. So, Dr. Amy Hoffman, I don't want to retire. We talked to you today. I think for now, most people can take it sort of like around breakfast, lunch, and dinner. You know, I think that's a good question. What happens overnight? By not taking it, you dip a little low. But I think for most patients, taking it 2 or 3 times a day with meals is okay. And it's probably okay to take your second dose mid-afternoon. I think the morning one is sort of the key one that people are focusing on right now.
Awesome. We have one more question. Pat asks, NP Thyroid has very reasonable pricing directly from the manufacturer. At this point, they're not licensed for mail order in California. Is there a possibility of someone such as yourself encouraging them to get the license?
I think they work with a lot of pharmacies that are licensed in different states. There's one called Delta, there's one called Highland. So I think in general, most of my patients are able to get it without a problem. And it doesn't seem to be too expensive either through GoodRx or through Delta or through Highland Pharmacy.
Awesome. Where's the best place to get NP Thyroid?
So, again, most people can just get it from the regular pharmacy. I think if it's an insurance issue, they're not covering it, then you may have to go through the Delta or the Highland pharmacies or GoodRx, and you may need to shop around for your source. It's pretty readily available. I think a while ago there's some shortages, but it doesn't seem to be any shortages now.
All right, awesome. Well, I think we're good on questions here, unless anyone has any last words.
Okay. Thank you so much. So we'll try to, there's a couple of thanks yous. So we'll try to maybe talk about the testosterone delivery in the coming talk, but hope everybody enjoyed this, and it should be posted on my website shortly. And thanks everybody so much.
Thank you.
Thank you, Dr. Friedman.